Good morning, everybody. This is Daryl Diamond with the Association of Community Cancer Centers, and we're happy you could join us today for Oncology Pharmacy's Role in Alternative Payment Models, featuring Dr. Amy Sung, PharmD and BCOP. Dr. Sung is the Senior Director of Clinical Development at Physician Resource Management, PRM. In this role, she leads strategic user development and clinical content for the CARET platform. Previously, she was the Oncology Clinical Decision Support and Hematologic Malignancies Pharmacy Clinical Specialist at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins Hospital, where she also served as Director of the PGY2 Oncology Pharmacy Residency Program. Dr. Sun received her Doctor of Pharmacy degree from the University of North Carolina at Chapel Hill and completed her pharmacy practice in oncology specialty residencies at the University of Washington Medical Center and Seattle Cancer Care Alliance in Seattle, Washington. She serves as the co-lead in the development of the National Comprehensive Cancer Network, NCCN, standard chemotherapy templates. She is active in the Hematology and Oncology Pharmacy Association, HOPA, and is the past chair of several BCOP recertification committees. Dr. Sung has authored multiple oncology articles and several book chapters. Thank you for joining us this morning, Dr. Sung.
Thank you very much. Good morning, everyone. To disclose, I do lead clinical initiatives for a healthcare technology company, and in that role, develop end-user functionality as well as clinical content for the software program, including analytics for outcomes for oncology practices. And in this presentation this morning, I will not be discussing any off-label use of medications, nor mentioning any brand or commercial product. Our goals today are to summarize key concepts for Macra legislation, including MIPS, as well as APMs, and their impact to oncology practices. Following that, we'll talk about the current CMS oncology care model, OCM, and the requirements for practices and you, the pharmacist within those practices. And then we'll examine the critical role of the pharmacist within the full healthcare team that participates in APMs, focusing on the challenges and then those solutions to be successful. So the bottom line here is that there's payment reform that's going on based on legislation that went into effect in 2015. And the goals for the practices here are multifold. First, the practices are going to need to develop new methods for data collection. They're going to have to adhere to new and dynamic standards of care for oncology patients. They're going to have to optimize performance outcomes and resource use. And they need to do all of this without negatively impacting the quality of care or the cost of care to their patients. And so our goal for today is not to make sure you have all the rules down and understand all the legislative ins and outs and how to bill for services, but to teach you how this is affecting practices and how your role is valuable and significant to help meeting this goal for practices and ultimately the patient. So how this has come about is through Macra, which is the Medicare Access and CHIP Reauthorization Act of 2015. Macra actually makes 3 significant changes to how Medicare will pay for those who give care to Medicare beneficiaries. And these changes create a QPP, or Quality Payment Program. We'll be going through a lot of acronyms today, and so really the goal is for you to have a good understanding of what these acronyms mean via words and how they'll impact you. And so what Macra does is end the SGR formula. This has been the formula called the Sustainable Growth Rate that determines Medicare payments for healthcare providers' services. So that's the first thing Macra does. Secondly, this legislation makes a new framework for awarding healthcare providers for giving better care, not just more care. And so this is where the phrase that we're all talking about, value more than volume, comes into play. And finally, the system or the legislation actually combines existing quality reporting programs into one new system. So all of the similar components are there with some added ones, but it puts it into new, hopefully less fragmented framework. The important thing to also recognize here is that while this is a government-mandated change for Medicare patients, many private payers are also considering changes and utilizing alternative payment models. And so, again, this is originally put together by legislation for Medicare, but this is going to impact all of us through many payers. So under Macra, there's two paths that providers can follow, MIPS or APMs. And so both paths link quality to payments. It requires that there's a quality measure development plan that makes different clinicians have different quality metrics that support both MIPS and APMs. And the effective date for this, for payments going through, is January 2019, although the first measurements are going to be based on 2017 performance, which is why it's critical to have practices on board now and for all of us participating in the care of patients with cancer that we know what our role is and know exactly what we need to do to help our practices meet performance measures. So under Macra, MIPS is the default Medicare physician payment system. With this, many, if not pretty much everyone, all the oncologists will start in MIPS and likely transition to APMs over time. MIPS will provide both positive and negative payment adjustments to physicians based on their performance across a number of different categories, which we'll go into a little bit further. MIPS is designed for providers in really the more traditional fee-for-service through Medicare, and advanced alternative payment models, or APMs, is designed for providers who are participating in specific value-based care models. Just to give you some numbers on those oncologists or those providers across the country that are subject to MIPS versus alternative payment models, I've seen numbers recently that over 700,000 physicians will participate in MIPS when it first starts versus 30 to 90,000 that will participate in APMs. So again, the vast majority of practitioners will be participating in MIPS as all of this really starts. So MIPS, or the Merit-Based Incentive Payment System, now utilizes three major programs. So PQRS, or the Physician Quality Reporting System, Meaningful Use, which we've gone through different phases of meaningful use, and then VBM, or the value-based modifier. So what MIPS does under Macra legislation is actually rolls together and sunsets these three kind of legacy CMS programs. So meaningful use, PQRS, and the value-based payment modifier. What happens effective January 2019 is that all of these programs will go into a single program, and additionally, a CPIA, or the Clinical Practice Improvement Activity, will be the fourth component here. By combining all these, there will be increased incentives, and then this program ranks practitioners nationally for their quality metrics. So under MIPS, this will be a combined weighted score of resource utilization, quality reporting, the CPIA, and then meaningful use, which under MIPS is now called Advancing Care Information, or ACI. And so to think about this really more specifically for oncology, while the final rules have just come out for the beginning in October, there's still a lot of unknowns in terms of exactly how oncology practices will put all of their metrics together. But overall, in terms of quality reporting, think about the fact of using qualified clinical data registries. They're called QCDRs. COPI metrics, which a lot of practices for oncology participate in with ASCO, is a cancer-specific designated clinical data registry. And so that might be one way to participate in quality reporting for MIPS. The CPIA, or the Clinical Practice Improvement Activities, again, this encourages providers to engage in activities that improve the quality of care. So again, COPI metrics and COPI certification may help practices or providers to participate for CPIA through that. Meaningful use, or the Advancing Care Information Program, there's some additional improvements over meaningful use that ACI would include. It's important that there's widespread interoperability of the different electronic systems that are used throughout a practice. The information exchange to different healthcare providers for a patient is really critical to meet that performance metric. So when you're thinking of these, there's definitely things, these aren't new metrics, these are taking what you're measuring now in practices and being able to apply these to the different MIPS components most effectively. So we're going to switch gears. We've talked about MIPS. APMs, again, it's a different model, so two different directions that a practice or provider may go. However, a lot of the metrics that are being captured for APMs are the same ones that are being put together for MIPS. It's just a different payment model. Under Macra, there's several different things that can qualify as a Medicare qualified APM. The four different ways are a Medicare shared savings program through an accountable care organization, or ACO. There's a model expanded under CMMI that's not a Healthcare Innovation Award recipient. There's also availability of Medicare healthcare quality demonstration programs or acute care episode demonstration programs, or it can be qualified as an APM through a demonstration program that's required by the federal law. So these are the four different ways that an APM can be Medicare qualified. So to be accepted as an APM under Macra, it's required, the programs are required to be an advanced APM. So in this regard, there's a couple of requirements here. The practice has to use quality measures comparable to measures under MIPS. So again, we've just mentioned that the metrics are the same, but the payments are different. They need to be using a certified electronic health record. They need to assume more than a nominal financial risk, or be a medical home expanded under the CMMI, and we'll talk about that more. And then finally, to participate in advanced APM, they have to meet a volume threshold of Medicare payments or beneficiaries. And so that is all very clearly defined now in the final Macra rules that have come out. And so that's how a practice and a provider would figure out the different qualifications as they are going into this new payment model. So Macra has defined what the advanced alternative payment models are for 2017. When you scan this list, so shared savings program, next generation ACO, comprehensive in ESRD or end-stage renal disease care, and comprehensive primary care plus, you'll see there's nothing oncology listed. This has been one of the biggest challenges to our practices and to caring for patients with cancer. The CMMI Oncology Care Model, or OCM, is coming in 2018. This is their two-sided risk tracks. This means that really when performance metrics start in 2017, there's not an advanced alternative payment model for oncology practices yet. And that's where the majority of practices will be coming in under MIPS, at least to start. So when we're thinking about, we just mentioned that all these alternative payment models that are advanced under Macra are not oncology focused. There's a lot of work being done for oncology focused APM. So the largest of these is the CMMI Oncology Care Model, and we'll spend more focused time on that in just a little bit. What I want to focus here is that although each model varies in its structure, its scale, and its phase, each one of those shares the goals of increasing access to higher quality care and better outcomes for our patients with cancer, while also at the same time trying to lower the financial burden on each individual and the healthcare practice or the healthcare system overall. And so the goal here is that the oncology-specific models, like the other outside of oncology models, really try to align financial payments with the quality of care and other performance outcomes rather than each kind of fee-for-service or billable service. And by doing this, by trying to link those financial incentives to quality and value outcomes, you may be able to have more flexibility at the provider level to develop kind of the most appropriate and cost-effective treatment plans. And so really the focus here is to incentivize oncology practice to pilot different care models and figure out the one that best fits their patient population and complements their specific practice goals. And so with that, you know, I would say the theory or the goals here are to kind of create a better relationship between payers and providers, at the same time providing this quality care with potentially a lower excess cost. And so when we're talking about oncology-focused APMs, you know, there's a lot of different models here, and we're going to talk through some examples that are being proposed. So when we're thinking through alternative payment models, think about all the ACOs, so accountable care organizations. There's bundled payment models. There's advanced oncology patient-centered medical homes. Again, there's a lot of demonstrations with patient-centered medical homes in the primary care setting. Now they're starting to be a lot more in the oncology care setting. One of the newer alternative payment models that's been proposed is a physician-focused payment model. And then remember that different pathway programs have physician risks and rewards that are also part of this alternative payment model plan. I think one of the most interesting things that I found as I was going through, I would say, the recent wave of literature regarding oncology alternative payment models is a group that convened together that included the American Association for Cancer Research, the Personalized Medicine Coalition, as well as the Feinstein-Keene Healthcare Group. These three groups came together. They created a Turning the Tide Against Cancer initiative, and in July of last year, so 2015, convened a roundtable with a multidisciplinary group of different stakeholders to discuss ways to identify and figure out key considerations for oncology-focused alternative payment models. And so the ultimate goal here was trying to understand how APMs can best support you know, patient-centered, high-quality oncology care and promote innovation that we know continues to come within our cancer practices. And so they had 5 major recommendations. And as you're thinking through different oncology patient, you know, alternative payment models and your role as a pharmacist and your department's role, think about how you fit in within these recommendations. The first one was to incentivize the adoption of both innovative medications and medicines and technologies that will actually have the potential to improve patient outcomes and make healthcare more efficient. The second was it was important that APMs encourage patient participation in clinical trials, as well as continuing research and post-marketing designs of trials, and how to get patients involved and really encourage those through their the payment models. The third was to create and then maintain updated clinical pathways. They're both transparent in their methodologies, they're evidence-based, and they reflect current scientific evidence within the overall continuum of care. So not just at the first decision treatment point, but along the entire way, either through survivorship or through palliation. And I think one of the difficulty, and we could talk about pathways for more sessions than time allows, but I think one of the difficulties here is keeping those pathways as current as possible and having different payers buy into what those current treatment strategies are, knowing that different abstracts and different papers are coming out each week, and keeping up with that is extremely difficult. The fourth thing was, during the time of treatment decisions, being able to give patients a clear, comprehensive picture of all of their treatment options. That would include cost, for example, risks and benefits, and it needs to be tailored to that specific patient's coverage, as well as their thoughtful treatment plan. Finally, clinical data should be aggregated and integrated into providers' workflows in their EHR. And I think the tricky part of this one is in order to support learning within the healthcare system. So right now, a lot of our EHRs, we put data into the EHR, but we don't get that real-time feedback on, we have this many patients that have undergone this therapy, and this is what their outcomes look like. This looks like it's going to be successful for our patient population. And so it's important to have those results back so that your system is continually learning and you're able to guide future decisions on specific outcomes. So to walk through a couple of different oncology alternative payment models, this is a model, Peacock, Patient-Centered Oncology Payment Model, that has been proposed and developed by ASCO. I will say this has not been adopted as a Macra, advanced alternative payment model at this point, but this is one that has that is really fully laid out by ASCO right now. This model could save money for the Medicare program. It provides resources to oncology practices, again, focused on high quality, high value, and really helps practices plan cancer care in a way that avoids kind of the expensive hospitalizations and admissions and unnecessary tests and treatments. And it does this through, again, getting fee-for-service reimbursement, but also providing services in new areas. And so 4 of the things that they recommend or that are within their program is payment for new patient treatment planning, payment for care management during treatment, payment for care management during active monitoring. So this is when a patient may not be getting chemotherapy or treatment itself right now, but they still need to be actively followed up and monitored. And then 4 would be payment for participation in clinical trials. So again, this model has been developed by ASCO, developed by oncology providers, knowing what some of the highest value items are within their practices. One of the most recent announcements, I would say, that came out actually in the month of November, a couple of weeks ago, is the ASCO Come Home model. This is a collaboration between ASCO and the Innovative Oncology Business Solution, so IOBS. This is an oncology medical home program that's designed to transition community oncology practices from volume-based to value-based care. It structures reimbursement around the full range of services needed by patients, and they have put together a lot of tools to increase practice readiness and implementation. And so there's tools for practices to assess whether they're ready to transition to an APM, and then also tools for practices that are actively engaged but need to make the changes. And they may be good in certain areas but need to make changes in very specific other areas. The initial Come Home practices, there's 7 of those. They have shown early results that showed a reduction in, for example, 30-day hospital readmission rates, emergency department visits, and showed an overall cost of care reduction. The other thing that they assessed that they've reported on is an overall high patient satisfaction rate through kind of the early pilot period. And so this is a program that is coming together between ASCO and IOBS. And so more to come on that, but that's something that may be helpful for all of the practices moving forward. So now I'm going to move on to OCM, or the Oncology Care Model by CMMI. And this is where this has probably been the most advertised model. This is right now the one model that will come in under the Advanced Alternative Payment Plan in 2018, and so there are lots of practices that are actively engaged and focused on this kind of in their everyday lives right now. So this is a multi-payer model in which practices will go into payment arrangements. It includes both financial and performance accountability, and it looks at episodes of care surrounding chemotherapy administration. It's a 5-year model right now. It began in July, and it runs through the end of June 2021. The overall goal here is to provide high quality, highly coordinated oncology care at a lower cost. So right now, there's about 200 physician group practices, as well as 17 payers that are participating in OCM. This represents more than 3,200 oncologists and covers about 155,000 Medicare beneficiaries across our country. It's interesting that there are a lot of commercial payers participating, and that's to really help align with Medicare and to create broader incentives overall within the practices. So under OCM, there's really a 2-part payment approach. One is a monthly per beneficiary care management payment. And so it's really intended to cover the cost of managing and coordinating care. And then the second is a performance-based payment for each OCM chemotherapy episode. And these are these performance-based payments are awarded to practices based on how well they perform in relation to benchmarks calculated by CMS. So they're adjusted for geographic variations and trended to the performance periods. And so the size of this bonus could potentially change based on how well the practices perform on quality measures. So in terms of thinking about OCM episodes, and this is where I think pharmacy really comes into play. So the OCM episodes are triggered with a Part B chemotherapy administration claim or a Part D chemotherapy claim and a diagnosis for cancer. Only outpatient chemotherapy will trigger a new OCM episode. So if a patient's inpatient at some point during their 6-month episode, the cost will still be included, but that inpatient chemotherapy visit will not trigger an episode. It's important to know that OCM covers all cancer types and focuses on all cancers that are treated with chemotherapy. It excludes things that are only treated with surgery, radiation, or topical chemo. So really systemic chemo, it can be IV or oral. If patients enter hospice care, that ceases the episodes as well. So that's just something to keep in mind there. And you know, practices participating in the OCM, you know, have really committed to meeting these goals. So they've committed to providing these enhanced services to Medicare beneficiaries. They need to coordinate appointments within their practice and outside the practice to ensure timely delivery. There needs to be 24/7 access to care when needed. So that means triaging appropriately at off kind of normal office hours. They need to arrange diagnostic scans and follow up with other members, other specialists, other referrals that are necessary for their patient's care. They have to make sure that any data needed to make treatment decisions is available so that patients don't have to come in for additional visits. And then it's important that additional patient resources, so support groups, pain management, clinical trials is all there as part of visits and easily accessible to patients. So some of the other things that are required through OCM are use of EHRs that have been certified, use of data for quality improvement. So practices will be submitting their data to CMS and then really trying to look at their data, committing to looking at their data to make performance improvements within their practices. Practices are required to navigate and document their Institute of Medicine care plans. There's 13 elements as part of that plan, and they've got to document it within the patient's medical record within the EHR at least once during each 6-month OCM chemotherapy episode. And then use of care chemo that's consistent with clinical guidelines that are nationally recognized. So the practices must show that they're treating patients that are consistent with national guidelines that are evidence-based. And then finally, they've got to report data back to CMS on a quarterly basis. There definitely are some initiation kind of goals of submitting data that are not that are kind of early on in terms of early adoption. And so practices don't need to submit all of their data like immediately, so there's kind of a phase-in approach to this. So you can see that there are lots of requirements. This is where, you know, practices are kind of in the being overwhelmed stage right now, and so there's lots of opportunities for pharmacists that really need to be involved, you know, pulling in pharmacy services, but also showing where pharmacists increase the value and increase efficiency of the medication use process. So some of the just generalized oncology practice goals and activities. So again, adherence to evidence-based chemotherapy regimens, avoidance of admissions, so thinking about early palliative care, for example, symptom management, extra visits or different types of visits or follow-up phone calls, triage pathways, reducing the length of stay through either more efficient discharge planning as well as coordination, thinking about transportation, for example, and other psychosocial issues. And then finally, coordination of care and patient navigation. There's a lot of different places that all the members of the healthcare team have to be involved here. So think about what you're currently doing and how your staff, your department are currently participating in each of these activities. So in terms of, you know, the pharmacist's role, there's a lot of leadership roles here. Really, for OCM and other alternative payment models to be most effective, the pharmacy needs to be part of the executive leadership of the practices, both in terms of goal setting, setting practice strategy, and resource planning. The pharmacist will be involved in advancing clinical standardization, developing value-driven approaches, and really creating those evaluative drug therapies, collaborating with the teams to implement medication guidelines that support cost-effective use, and then being able to have the authority to intervene when there's equally effective, less expensive medications. It's also critical for the pharmacist to be involved in software technology decisions that will both help support pharmacy activities as well as the overall practice activities and goals. In terms of the day-to-day pharmacy and pharmacy technician roles, there's definitely patient care responsibilities. As there's more put on the entire medical team, you know, pharmacists have been shown to improve both clinical and cost outcomes of patients in multiple studies. And it's important that they be at the table to help extend physicians' responsibilities and be able to reach those patients that are at highest risk for potentially poor outcomes. So there's roles there for medication therapy management, adherence, checkups for high-risk patients, counseling and education. Through medication management, you know, increasing efficient and safe dispensing practices, formulary management, driving the use through protocols of highest value medications. I think the data management is one that we could, again, spend an entire session on, but looking at pharmacy dispensing software data. So you may be the only ones that truly know when drugs were dispensed and when oral medications were started, for example. Also being able to take your pharmacy documentation, pharmacy interventions, the value that you're often using for showing your own budgetary needs for FTEs, for example, and being able to aggregate that with the rest of the practice data. That's critical. When we talk about challenges, and I think you can all probably think of lots of challenges within your own practices. One of the biggest ones, I think, is that there's multiple quality initiatives. I've listed a few here for you. You've got pharmacy quality initiatives, both probably locally as well as on a larger national basis. There's multiple quality initiatives within your practice and within your kind of region, and then nationally that you're all participating in. It is really hard to try to do all the reporting and paperwork for different quality initiatives, and so it's important to think about what the biggest goals are. And as you're thinking through pharmacy initiatives, how do those mesh with what the overall practice quality initiatives are? Other challenges, I think, have to do with just daily workflow and workforce. So time. All of us need more time to document quality initiatives and to report, and then to actually look at those outcomes. You also need to make sure you have a variety of experienced personnel that will help you think through ways of gathering additional information that you may not be capturing right now and how to do that efficiently. Workflow challenges. I think one of the hard ones is adequately identifying the gap in practices where you think changes could occur. So not only collecting the data, but then figuring out where you can implement change to then improve your next set of data. Being able to capture identified data points in your standard workflow versus doing extra documentation just to meet a quality metric. This is one of the ones that there's really money in, truly, that if you can figure out a way to put quality metrics into your everyday workflow so that your staff don't even really need to think that, oh, I've got to capture this because it's got to go towards COPE or it's got to go towards this pharmacy goal, that it's just part of normal workflow, is really one of the biggest ways to be successful. And then really, in your workflow, you want to have the ability to impact change from the results. So again, that learning system of feeding back your data to implement change. One of the ones that I think is one of the biggest pharmacist challenges just within alternative payment models, regardless of quality initiatives that you're working on, is the lack of recognition as providers. So under MIPS, pharmacists are not eligible clinicians, and under most APMs, such as different ACOs, pharmacists are not required providers. You know, there's lack of pharmacy service billing methods. There's a lot of national pharmacy organizations now that have created white papers or statements talking about the importance of effective integration of pharmacists and all their services into these quality payment models or alternative payment models. And so there is, again, at the state level, lots of different legislation about making pharmacists recognize providers and being able to bill for services. But I think that'll continue to be a challenge for us all in figuring out ways to efficiently increase your quality initiatives, but then also get return on investment there. So how do we meet the challenge? I think one of the biggest things, which is how I've really thought through talking with you today, is educating your staff. So your staff need to learn the Macra, APM, and OCM language. That makes them more intelligent and part of the team at the table as they're interacting with all of the different team members and patients on a daily basis, understanding the timelines, the data challenges, and the potential quality gaps. Again, your staff are all your eyes and ears and hands across the practice and the institution. Participation in multidisciplinary team planning and being able to explain that rationale for new activities and data capture, that really being able to answer the question, what's in it for me or why, is critical for being successful in creating value, you know, as a pharmacy staff for alternative payment models. One of the key things that I think pharmacists have a huge role in is helping the practice build a process or mechanism to track patients through a chemotherapy episode. You know, defining what that 6-month episode is very difficult. Then you need to think about your systems, your electronic systems in place, and how you can capture when that day 1 of an episode is and when it ends. And then it being able to contribute that pharmacy data to meet all the aggregate data needs. So looking at that total cost of care and all those different pieces involved. And again, because of pharmacy's role in the medication process, there's a lot of pieces that can contribute. I've been in several practices recently that didn't realize that pharmacy had some of those missing data pieces. So in a separate kind of siloed meeting, they were trying to think through ways to find this data while pharmacy actually had it within documentation of interventions and their dispensing platform pretty easily and readily available. So again, sharing of how to find those data gaps. And finally, I wanted to talk just a little about setting up your data capture. Again, this is multidisciplinary, but thinking about what elements are readily available. Is there anybody else collecting these? Have you already captured these in your daily workflow somewhere? Does somebody do this? Are there discrete fields in your EHR pharmacy software? Tag your fields, become friends with the reporting people that work on your software. Being involved at the very beginning with creation of very defined fields that aren't free text, being able to be involved with standard notes and order sets can help meet these OCM as well as other APM needs in the future. And I would say the final piece is being able to prioritize your actions. So as departments of pharmacy and leaders within pharmacy, we have a lot of different stakeholders. So thinking through who all your different stakeholders are, ranging from administration within your practices and different regulatory requirements, you know, through to the patient at the center of the model, at the end of it downstream, and thinking through what needs to happen at what point and what goals are really there for all of those different stakeholders. Thinking about feasibility, what is the low-hanging fruit that can meet a lot of requirements, what's going to take a lot more work and structure to be feasible there. Again, the benefit to multiple parties, your return on investment, whether that's financial, what kind of FTEs are required, or can you restructure FTEs, having your staff practice to the top of their licenses, and kind of the return to them so they can see value in their role within the entire model. And then finally, patient safety. So what of these initiatives really helps increase value and patient safety at the end? Again, documenting things in a team approach helps reduce duplication. And so prioritizing actions is pretty critical to making this all come together at the end. At this point, I'd like to thank you for your time. I appreciate your participation today.